students, this is Dr. Prats and welcome to my channel. Today is the last of the series on odontogenic tumors and we are going to study mainly the mixed odontogenic tumors and we'll also understand what is a continuum concept. Let's go. So all our presentations are in a questioning format and it starts with what is the pathology? Why do we need to understand the pathology? The three hows, that is, how did it occur, which is nothing but etiopathogenesis. How to diagnose using your investigating tools, that is radiography and histopathology, and if any other required. How to treat, very important, or how to plan your treatment. Followed by summary of whatever we learned. And lastly, and very importantly, answering multiple choice question. The objectives for this presentation is to discuss the mixed odontogenic tumors and also the ectomesenchymal tumor, that is cementoma. So I always tell you that you need to know the clinical features, radiographic and histopathological features, correlate all of them to arrive at a diagnosis, and that's exactly the sequence how we study oral pathology. And the mixed tumors which we are going to study is Amyloplastic Fibroma, Odentoma, and Amyloplastic Fibro-Odontoma. Amyloplastic Fibro-Odontoma will be discussed after Amyloplastic Fibroma and Odentoma. The discuss you will understand when you're listening to the lecture. So let's begin with the first mixed tumor, that is Amyloplastic Fibroma. And when I say mixed tumor, it basically means that it is derived from odontogenic epithelium and mesenchymal cells, that is from enamel organ and dental papilla both. That is why it is called as a true mixed tumor. Clinically, it usually occurs in the posterior mandible. It is a circumscribed lesion. When the lesion is enlarged, as you can see in this image, you can even see ulceroproliferative growth, usually seen in young patients, which is very, very important. And average age of diagnosis is about 14 years. And like I said, mandibular, premolar, and molar area are the most commonly affected. Coming to the investigations, the radiography shows, as you can see in this image, it shows a well-defined unilocular radiolucency. It could even be multilocular radiolucency. And 50% of the cases are associated with an impacted tooth, as you can see in this image. And histopathologically, it is very, very unique. Basically, you see an extensive stroma and you see long, thin strands of odontogenic epithelium. And the stroma which we see around is a primitive mesenchymal stroma. And these strands of odontogenic epithelium look like cauliflower-like proliferation within this ectomesenchyme. This is the most characteristic feature of amyloblastic fibroma. You have to be very, very careful when you're looking at the histopathological slides because there might be very few strands like these, and if you miss them, then your diagnosis will be inaccurate. The lesion is well encapsulated. Basically, it means that enucleation or enucleation, whatever you pronounce it as, that is sufficient because it easily separates from the bony crypt. But there are also some recurrences reported, so a follow-up will become essential. The next mixed tumor we are going to study is Odentoma. It is the most common odontogenic tumor, comprising almost of 70% occurrence. It is considered as a hamartomatous lesion, and this is commonly found over unerupted teeth. If you want to understand what is a hamartomatous lesion, I'll give a link in the description box below. It contains enamel and dentin and some amount of pulp and cementum. So it contains all the hard tissues, that is enamel, dentin, and cementum, as well as pulp. But depending on how they are arranged, it is classified into two types, that is compound odontoma, where the structures are very recognizable, meaning tooth-like structures. And the next type is complex odontoma, where you will just see a gnarled mass of hard tissue. So let's discuss each one of them separately. Let's begin with the clinical features of both together. Mean age of occurrence is 14 years. Most of them are small and resemble the size of the tooth itself, but they can even grow big as 6 centimeter or even more. Compound odontoma, the site is very specific and it is quite frequent in the anterior maxilla, and complex is seen in both the jaws, but it can be seen more frequently in the posterior parts of the mandible. So the site should give you some idea as to which type of odontoma it is, but of course only after radiographic and histopathologic examination you can come to a final diagnosis. So compound odontoma, as you can see, this has already been extracted. Radiographically, it looks like multiple calcified masses resembling tooth-like structures. They're not exactly looking like any of the teeth, like incisor or premolar or any of them, but it does look like a tooth. It resembles a tooth-like structure. And these calcified masses are surrounded by a radiolucent rim. It's very characteristic of compound odontoma, and histopathologically, when you see the sections, you will see that they look like a miniature tooth-like structure. Complex odontoma, we will see a calcified structure which does not resemble any kind of tooth structure. And here in this picture, you can see that this complex odontoma is preventing the eruption of an impacted molar. Coming to the histopathology, unlike compound odontoma, it doesn't really look like a tooth structure, that we already know, and that is translated in the histopathology as well. We will still see enamel space, dentin, and pulp-like structures, but it doesn't really resemble any tooth-like structure. And you can see that there is a well-defined capsule all around the tumor. This is just a comparison of the compound odontoma and the complex odontoma. You can very well appreciate the tooth-like miniatures in case of compound odontoma, whereas in complex odontoma, you will see the hard tissues. You cannot really discern what is what, and the pulp as well, but they're not really arranged in any specific organized manner. That's the difference between the compound and the complex odontoma. Anyhow, the treatment for both are same, that is enucleation, because both are encapsulated tumors and they can be easily separated from the surrounding bone, and recurrences are not really reported. Why I said amyloplastic fibrodontoma will be discussed at the end of all the mixed tumors is because of a concept called as Continuum Concept. So according to this, the tumor starts as an amyloplastic fibroma, and then some calcifications occur to form an amyloplastic fibrodontoma, and when this calcifications increases in amount, eventually they turn into a complete odontoma. So this is the theory of the continuum concept. So I wanted you to understand what is amyloplastic fibroma and what is odontoma, and so that now you can understand what is amyloplastic fibrodontoma. So by now you must have guessed that it is a combination of both amyloplastic fibroma as well as odontoma, and it has a greater potential for growth and destruction, and that is the reason why we must know this particular tumor. So clinically, it is seen in the first and second decade like odontoma as well as amyloplastic fibroma for that matter, and the site of occurrence, it can occur in any site. Radiographically, it appears as Well circumscribed, either unilocular or multilocular radiolucency. We are looking at the site of mandible over here, and like I said, it can result in extensive destruction, and even the calcifications can be seen as radio opacity. Histopathologically, we will see a combination of histopathological picture of amyloblastic fibroma and the odontoma, hence the name amyloblastic odontoma, isn't it? So you can see here that there are thin strands within the primitive ectomesenchyme, as well as in the other side of the section we'll also see calcified material, which might be depicting the calcified structures of the tooth. So that is the histopathological feature of amyloblastic odontoma. I think it's pretty easy, and it is quite interesting to see how you can appreciate both the features of amyloblastic fibroma as well as odontoma within this slide. So the management again is enucleation, but we need to be very careful because recurrences are quite common, especially when there is any little lesional tissue is left behind. So the last tumor is cementoblastoma, which is derived from ectomesenchymal cells, especially the cementoblasts. So it is defined as a benign tumor. It is quite well circumscribed, and it's a neoplasm of cementum-like tissue. And this is growing in continuity with the apical cementum, or the epiphysis of molar or premolar. And this could result in expansion of cortical plates and pain. So this definition itself is nothing but the clinical feature of cementoblastoma. That is the reason why you need to know the definition. It need not be word by word, because these days nobody asks you or expects you to know a word by word definition of so many oral pathologies. I think it's just impossible, but you need to know what it is, the basic terminologies which are important, like it is benign, it is well circumscribed, and where's the location? It is in the apical cementum of a premolar or a molar, and the clinical picture is expansion of cortical plates and pain. So like I said, it is attached to the epiphysis of a premolar here. You can see it's quite a big tumor, and you can see the clinical picture where it is seen in the posterior mandible. It is quite uncommon, and it is seen in the second and third decade, and pain is quite a common feature, like I've been telling from the first slide of the tumor. It can become intense whenever it is palpated, so that is quite unique for cementoblastoma. And another unique feature is that the teeth remain vital, so this will help you in differentiating from any other tumor or a cyst if you're doubting the presence of that. Radiographically, you will be able to appreciate three different stages. So osteolytic stage. So lysis means basically resorption. So this stage will radiographically appear as radiolucent. It is quite a logical reasoning behind that. And the next stage is osteolytic osteoblastic stage. So here what happens is that there is a mixed appearance. There is both radiolucency, and because of the formation of cementum, you will see some amount of radio opacity as well. And the last stage is maturation stage. This is the inactive stage where calcification increases and there is very less resorption happening. So the picture which you're seeing here is very much a maturation stage. You can see how the entire tumor is radiopaque with a very little radiolucent border. Histopathologically, you will basically see unmineralized eosinophilic matrix, which is rimmed by plump cementoblasts, and multinucleated cells wherever there is active resorption. I cannot really show you, it's not very typical picture, but you will see reversal lines, as you can see in both the images. So this is basically indicative of extensive remodeling, which basically means that there is simultaneous resorption as well as deposition which is going on. So that's the histopathological picture of cementoblastoma. Histopathologically, you cannot really differentiate between cementum or dentin or any other hard tissue. They all look hematoxyphilic basically. Regardless of the size of the lesion, the tooth has to be extracted because I told you that the tumor is attached to the epiphysis of the tooth. And another point which you will appreciate histopathologically is that there is no difference between the border of the tooth and the tumor, so it will become very difficult as to where exactly the tumor has to be excised. So because of this difficulty in figuring out where the lesion starts or where the lesion begins, it's better to remove the tumor along with the tooth. And the treatment of choice is enucleation because it is quite a well encapsulated tumor. And the recurrences have not been reported after the treatment has been performed. So like I always say, do not get overwhelmed. Just remember your clinical picture, radiographic, histopathology, and correlate all of them to conclude to a diagnosis, and then decide your treatment option. Okay, like I always say, do not get overwhelmed. Just try to recollect what were the clinical, radiographic, and histopathological picture, and you will easily come to your treatment plan. Clinically, you cannot really distinguish them unless in case of odontoma, you will see a kind of tooth-like structures jutting out on your soft tissue. So I think we need to depend a bit upon our investigations. So radiographically, in case of amyloplastic fibroma, it's a unilocular radiolucency. In amyloplastic fibrodontoma and odontomas, you will see radiolucency with some amount of radiopacity. So histopathology will become the gold standard for your diagnosis. In amyloplastic fibroma, there are long strands of epithelium within a very primitive ectomesenchyme. In odontoma, you have complex and compound odontoma. Compound odontoma mainly occurs in anterior maxilla, and complex odontoma occurs in posterior mandible. And histopathologically, compound odontoma resembles tooth-like structure, and complex odontoma looks like a gnarled mass of calcified tissue with pulp-like tissue. And amyloplastic fibrodontoma will show the features of both fibroma as well as odontoma. So that should help you with the diagnosis. So those were the three mixed tumors which we studied. What about the cementoblastoma? So cementoblastoma could occur in any site. It has three distinct radiographic occurrence: radiolucent, mixed, as well as radio-opaque, which is nothing but the maturation stage. And histopathologically, you will see mineralized tissue and even unmineralized tissue and reversal lines, which is showing continuous remodeling. So the treatment option for all of them is enucleation, except for cementoblastoma, it's enucleation along with the extraction of the involved tooth, because the tumor is very closely enclosing the epiphysis of the tooth. So that sums up the tumors very well, and I think it was a good summary of all the tumors which we discussed today, and that ends the series of odontogenic tumors. I hope it was easy. I hope it was very well explained. Let's see the MCQ of the day. If a patient comes to you and on radiographic examination you see a unilocular radiolucency, patient is still within the first decade of life. And when you do the histopathological examination, you will see a cauliflower-like proliferation is in the ectomesenchyme. So that could be diagnostic of which one of these tumor. Is it compound odontoma, complex odontoma, amyloplastic fibroma, or cementoblastoma? So in compound odontoma and complex odontoma, we'll see tooth-like structures. There is no mention of that here. In cementoblastoma, also we see calcified tissue with reversal lines. Again, there is no mention of that in the histopathological features. Unilocular radiolucency could be a radiographic picture of any of this. So because we ruled out compound, complex, and odontoma and cementoblastoma based upon their histopathological picture, amyloplastic fibroma has to be the answer for this. So students, if you like the way I explain things, please subscribe to my channel and share it with your friends. And of course, comment in the description box below and tell me what are the other topics which you want me to teach you or help you with. And if you have any doubts in the presentations which I've given, kindly let me know and I will clear all your doubts for sure. So if you like these MCQs and the way I explain the STEM and how to rule out your distractors and come to the correct answer, then please go to my website. There are plenty such MCQs for you to practice and get on top of everyone else. So these are my references. I think I've told you about the references in all the previous presentations. So thank you guys. Keep smiling.